Good evening, everyone, and welcome to tonight's webinar. Tonight's webinar is brought to you by SAAPD in association with SAAPD, South African Association of Paediatric Dentistry. Tonight's presentation will be presented by Dr. Rutendo Kudenga, the topic being pulp therapy in young and immature permanent teeth. Dr. Rutendo Kudenga qualified in 2015 at the University of Pretoria. She then went on to do her community service in Springbok, a small town close to the Namibian border. After that, she worked in private practice for 6 years. In 2021, she joined the Department of Odontology at the University of Pretoria as a full-time lecturer. Dr. Kudenga, a postgraduate diploma in endodontics from the University of Pretoria and a master's in global public health from the Queen Mary University of London. Dr. Kudenga is passionate about implementing change in public health systems to ensure health equity. Her interest includes both prevention and health policy. Dr. Kudenga, without further ado, I'm going to ask you to present. Just as a reminder for everybody attending, the CPD points will be uploaded to the HPCSA within 5 days of this event. The chat function should be used for any questions that they would like to raise. And a reminder for the SAAPD Congress for members and non-members to register, which will be happening on the 25th to the 27th July. Dr. Kudenga, over to you.
Thank you so much, Dr. Osman. I am going to share my screen now. Yeah. Hey, so welcome everybody. I hope you are as excited as I am. Thank you, Sada. Thank you, SAAPD, for this invitation. As we all know, kids are challenging and fantastic at the same time. It's an interesting experience for me all the time when I get to treat the little younglings. Okay, so my topic is in pulp therapy in young immature teeth. So my lecture view for today, I'm going to have a short introduction, then we're going to discuss the Dentine-Pulp complex, and then we're going to move over to vital pulp therapy. Then we're going to do materials. Then we're going to do what happens when you have a necrotic pulp. So the biggest issue we have, the dilemma we have with managing immature teeth is that we're never really accurate about the diagnosis of the pulp. Sometimes it's very difficult and challenging to determine, okay, is it necrotic? Is it inflamed? Is it reversible? Is it irreversible? Especially if a patient walks in and they're swollen, but you look at the tooth, you take an x-ray, the pulp still looks fine. So there's always those you question. I question a lot with these cases because you always wonder, what's next? Is it savable, or am I just imagining things, or am I overly being positive? What if the pain continues? What if I treat this kid and they go home and they still pain? The mother and the child will not like me at the end of the day. Should I save the pulp or not? Should I attempt it? Should I not attempt it? These are the dilemmas we are always faced with. And I always ask myself, have I ruined this kid's life? They came for help and now they leave feeling the same way, in pain, and I have not solved anything. Then we get other cases where we deal with kids like this.
Okay. But you're gonna do it because you can.
You take the pictures.
Yep, deep breath through your nose. Remember, relax, relax. You can do it. You can do it. Yes, you can, honey.
Did you notice that we're all wearing little elf outfits?
Yeah, you're at Santa's workshop. Do a really good job. Santa's gonna bring you an extra big present.
That's like a good idea.
I know, but you can. We do lots of stuff that we don't want to do.
And then you have kids like this. So a lot of the times we are really faced with situations where you begin to question, should I be treating kids? And as we all know, a lot of our colleagues have stopped treating kids completely due to management, and it can be tough. And sometimes when you face patients like this, it's easier to say, you know what, let's just extract. Then you have cases where I see at the hospital where theater is not an option. Conscious sedation is not an option, and you're stuck with, what do I do next? So I think it's very important that we understand in terms of what can the pulp do. I think in this essence, the pulp is actually more resilient than what we think. We need to actually give it more credit than what it actually deserves, because the pulp is a very excellent organ in our body that is good at repairing itself. It's good at strengthening against anything that comes against it. So next, I'm going to talk about the Dentine-Pulp complex, what it entails. As you can see, it's a close relationship between the dentine and the pulp. Okay. Although the dentine protects the pulp, we find that this becomes a defense mechanism, because the pulp contains the cells that defend the dentine. Whenever bacteria comes, the pulp reacts. So as you see from this picture, in a normal condition, this is what a normal pulp would look at. We would have fluid-filled dentinal tubules that contain, you've got your odontoblasts in there, you've got your nerve endings in there as well, and then you've also got shuts. As you can see at the bottom, you've got your blood vessels. They contain the dendritic cells that can transform when required as well. But as we know, the pulp can be injured. We can injure the dentine due to trauma, caries, iatrogenic mistakes, anatomical defects can lead to inflammation and pulp necrosis. But the issue is we need to stop it before we get to a necrotic pulp, because as we know, the more we prolong the injury, in terms of the longer we leave caries, it could lead to pulpitis, then irreversible pulpitis, then necrosis. So the key is that we need to catch it as soon as possible. So what happens? What defense mechanisms do we have? So when bacteria comes and it invades the tooth, okay, so what happens is that all the bacteria enters the tubules, then the receptors then come and they release cytokines that basically they cause the blood vessels in the pulp to dilate. Okay, so what happens is that the dendritic cells then move up into the tubules, as we can see here, and they start basically eating up the bacteria. So as you see that there is a response, but the key is that the injury must not stay for long. Then, of course, you have your defense mechanism that come from the odontoblasts. You can see from the histological slide I have here that when bacteria comes, it will secrete reactionary dentine. Okay, this helps slow down the process and the process of the bacteria as well, and protect the pulp. So it just keeps secreting it as it goes on. But there comes a point when then these odontoblasts, they die. And then what happens is that we've got reparative dentine. So the cells from the pulp are the ones that produce the odontoblast-like cells that releases that reparative dentine, which shows us that the dental pulp can repair itself and has the capacity to regenerate in any form, which forms the basis for vital pulp therapy. That is what vital pulp therapy was based on, the fact that the dental pulp can repair itself. Okay, so what can injure the pulp? As I said, trauma. As we all know, traumatic injuries happen more common in permanent teeth than in primary teeth. We have 58% in permanent teeth, 36% in primary teeth. Then you have your uncomplicated fractures that are the most common traumatic cases, from 41% to 68%. Then we have pulpitis and necrosis that can occur due to dentine being exposed to bacteria in uncomplicated or complicated crown fractures. So the fact that the fracture is open and we've exposed the dentine that can also lead to our pulp being injured. Okay, so the incidence of pulp necrosis in uncomplicated fracture is actually 2 to 5%. But when the injury is in the periradicular tissues, then the chances of necrosis happen. So this is your avulsions, your intrusion, anything that disrupts the neurovascular supply of your dental pulp will lead to necrosis. Okay, so, and we've also noticed that literature has shown that a traumatized dental pulp in immature open apex teeth will have a greater chance to heal and actually survive more than in a permanent tooth. Okay, so in teeth with closed apexes, there's a 55% to 65% chance. And then within open apexes, there's a 3.5% chance to 11% chance that it becomes necrotic. Now, caries also injures it. And as I said, it's very important that we treat it as soon as possible to prevent injury to the pulp. And early treatment will maintain the vitality of the pulp. Okay, then we have our dental anomalies, your dens invaginatus. As you can see, it will look like a little cusp, a second or third cusp that sits on the tooth. And then when you look at the X-ray, you can see that the root here hasn't formed, and there's a radiolucency at the apex. Okay, so these form without caries. Your patient will walk in, they'll be in pain. Very rare, you see 1 or 2 sometimes you don't see them. But if the pulp is vital, what you can do is that you can place composite around it to prevent it from fracturing. Sometimes you can actually slowly reduce it, that extra pulp that sits there, and you monitor it. Then you've got your dens invaginatus, which we all know can cause pulp injury as well. And then you've got your palato-gingival grooves. Okay, this is normally associated with localized periodontitis. It's not very often you see it, so you end up with the endoperioral lesion. Okay. So next question is, why vital pulp therapy? No, so now the procedure is done to preserve and maintain the pulp health. It's performed on teeth with healthy pulp or reversible pulpitis. Treatment is done to remove the bacteria and induce tertiary reparative dentine and a calcific bridge over injury site. So the main thing here is that we're trying to get, especially in immature teeth, we're trying to get the root to fully form. That's why we perform it before it becomes necrotic, anything like that. Because the moment it becomes necrotic, then it becomes difficult for the root to fully form. Okay, so why pulp therapy? Because we need to maintain the space. As much as we would like the easier route, which is taking out teeth over kids screaming and we're tired, we need to maintain the space. Okay. The moment we keep the tooth in, we aid our patients, okay, in speech and chewing. Okay. And as we all know, happy child is a happy parent. The moment that child is happy that the pain stops, the parent is also happy as well. Okay, and most important, we have to allow for the progression of the root development in order to keep that tooth in place. So our procedures include indirect pulp capping, direct pulp capping, and pulpotomies. Okay, so in indirect pulp capping, we are treating deep caries close to the pulp. I'm sure we all know this. We do these a lot on permanent teeth. And the key thing is that the pulp must be healthy or reversibly inflamed. And that's the main thing. If you want to do pulp therapy, your diagnosis of the pulp needs to be accurate. It must be healthy. It must be reversible pulpitis as well. So the key with this is that there's no periapical radiolucency. Anything that screams irreversible pulpitis is a no-no. And they mustn't be widening of the PDL. Okay, so the procedure requires you removing most of the caries and leaving a thin layer near the pulp. Then you must place a protective material to protect the pulp. As you can see from this X-ray, this was caries on the molar. Okay. and then they left a little bit of infected caries there to prevent pulp exposure. So, and then they place the material. So this procedure is very controversial. A lot of literature says one thing, the opposite, completely opposite. The Association of Endodontics in America actually says that they don't believe in this. They don't believe in leaving caries. You must remove all the caries so you can actually visualize the pulp tissue. Conditions, because a lot of the times our tests will tell us that it's a necrotic pulp, but the moment you open it up, it bleeds and you can actually maintain the bleeding. So that's their basis. And then other people are like, no, but it's better we leave the little caries we have there instead of exposing the pulp. So it depends on your experience as well and what you've seen. Okay, you can try. I don't think there's harm in trying to be more conservative. And then if that doesn't work, doing something else. Okay, going a bit more invasive. Okay, then we have a direct pulp capping. So this procedure is used to place medication on the exposed pulp and then covering it with a protective barrier and then placing a final restoration at the same visit. It can be done over 2 visits as well. As we can see from this X-ray, you have a complicated pulp, complicated fracture, and then you take your slow handpiece, you go in 2 millimeters of the pulp is removed, you place your material over that pulp tissue, and then you restore it, okay? Then you have your pulpotomies. This is removing the inflamed coronal pulp to preserve the vitality of the remaining reticular pulp, the pulp that's in the root. We have partial pulpotomies, which is the removal of the superficial layer of the infected or injured one. Okay, then we have our full complete pulpotomy, which is removing the pulp in the pulp chamber. So as you can see from this case that was done, that this was, as I said, it was reversible pulpitis. They removed the chamber of the pulp and then placed their material. And then as you can see from the X-ray, it also induces root formation. Okay, so the key thing is to follow up on your patients. Then we have this case. So this was actually a very interesting case. When I say when the Endo Association of America actually says, because a lot of the time, you have case studies. Literature says you can do vital pulp therapy on irreversible pulpitis. That's what they say. But you have different case studies that come up, although the Paediatric Association of America actually says that you can only do it on healthy pulp. Do not attempt it on irreversible. So there's different contradicting criteria out there, but this case, they actually tested the pulp and it was necrotic. They did every test. The code test was lingering, but the moment they opened it up, they found that it was a vital pulp. So, which is why I said it's a dilemma. Sometimes your tests could be wrong, okay? And your test says it's a necrotic, but when you open it up, it's vital. And as you can see from the X-rays, you can see that the root formation actually continued after they did a pulpotomy on it. Okay, so what materials do we have? We have our MTA, which is biocompatible. It's antimicrobial. So this is the gold standard. It has increased marginal adaptation and therefore has less leakage. It has improved sealing properties. It induces osteogenesis and promotes healing. But there are discoloration. You can get an MTA that's white as well. I think ProRoot has a white one, but that one also kind of turns gray. So I don't normally recommend it for anterior teeth. The Angelus one is the one you can use for anterior teeth. So this has a prolonged setting time. So normally when you put it in, I normally put a liner on top of it because of the prolonged setting time. And of course, it is expensive, but success rate is very high. Okay, and then you have your biodentine. This one's biocompatible, antimicrobial activity. It also increases your marginal adaptation. You have a high bond strength, and it can induce odontogenic differentiation and formation of reparative dentine. And as we know, it has a high cost. but the success rate is at 98.3. Then you have your calcium hydroxide. So a lot of people have stopped using calcium hydroxide due to the fact that it dissolves after about 1 year and it has poor sealing properties, okay? But it is biocompatible. It has antimicrobial activity. It induces a calcific barrier. It promotes healing and repair. It stimulates fibroblasts. It's inexpensive, which is a good thing, and it's easy to use. Okay. So its success rate is actually 94%. So literature says to increase the success rate of calcium hydroxide, if you disinfect your pulp with chlorhexidine, it actually increases it by 97%. Okay, so that's one way you can increase the success rate of calcium hydroxide. Now, any material that has resin, I would recommend you put it on indirect pulp capping, not direct, due to the fact that it has resin and its cytotoxic effect as well. So advantages of your resin modified glass iono is that it's biocompatible, it's antimicrobial activity, it has ability to bond to the enamel and dentine. It has high mechanical strength, its uptake and releases fluoride, and it has a 96.5% success rate. And the success rate also increases when you disinfect the pulp area with chlorhexidine. Then we have Theracal, which is light cured. It enhances physical properties. It has low solubility, improved sealing ability, high calcium release, induced formation of dentine bridge. And it's one of the disadvantages is that it has an opaque whitish color. Okay, so don't use it in anterior teeth because then you see that white line. Okay, and its success rate is at 87.8. Okay, so after discussing all this, sometimes the diagnosis of your pulp is a necrotic pulp and you have to remove it. You have no other option. Then what next? So this is always something that you do when your vital pulp therapy has failed. You have done a pulp cap, you've done a direct pulp cap, whether it's a full pulpotomy, whether it's a partial pulpotomy, and then your patient comes back and they're symptomatic. So, and remember, this is an immature tooth. So you don't obturate it as normally as you do a permanent tooth. So the question always lies, what if I have to remove this pulp? What next? Okay, so the treatments for immature tooth with pulp necrosis includes apacification and regenerative endodontic therapies. Okay. So I do a lot of these cases and I enjoy them. And I must say the kids have been quite cooperative. There are a couple that I've had to take to theater, but I enjoy doing these cases. So apacification is when there's no vital pulp being preserved, okay, because the pulp is necrotic. A calcific barrier is formed after the placement of calcium hydroxide in the long term, or a barrier is formed using MTA as an apical plug. So what they do with the calcium hydroxide is that they do an ERCT, they take out the nerve, and then they place calcium hydroxide, and then they follow up after 6 months. Okay, so sometimes a calcific barrier can be formed at the bottom, but MTA as an apical plug gives you more success. Okay, there's no further root development here. It's basically what you're trying to achieve is to close the pulp so that you can obturate with GP. That's ultimately what the goal is. So this is one of the cases I did. We had to take this kid to theater. He was an 11-year-old boy. He presented to the hospital 1 week after the injury. He wanted nothing to do with anyone. It was his first time at the dentist. And as you can see, he had a complicated fracture. To our advantage, the mom actually kept the piece. She put it in sterile water and she brought it to the hospital. Okay, so I did this case in theater with one of my colleagues. Okay, and as you can see, as I said, the pulp was necrotic. You can see from the color, we did test, no response whatsoever. As you can see from the X-ray, the kid also had a mesiodents as well, right between his 1-1 and his 2-1. And you can see from the pen as well. So what happened was that the tooth had actually extruded, and the boy was very anxious and in pain. He wanted nothing. He did not want to see anyone at all, which is why we made the decision to take him to theater. So I put in MTA. As you can see, I had my working length. We use K files. This was up to a size 80. And then I put my MTA, and I put about 4 to 5 millimeters from the apex of MTA. And then this was the final product. We managed to use the remnant that was left, the fractured part. We bonded it in with composite, and then we removed that mesodents for the patient. And this was the final X-ray. As you can see, we closed that apex. The patient says they are fine. I haven't been able to see them for a follow-up. I'm hoping to see them next month. But so far, the father says the child is fine, happy, and happy as well. Then I had this case. So this second case, this patient, 8-year-old boy, who came in, fractured the 2-1, okay, and an emergency root canal was done in the service rendering department, the emergency department in the hospital. So I took on this case. Okay, so I learned a lot from this case. So firstly, I filled up this whole canal with MTA, which is not advisable. Okay, so it's advisable that you just do 4 to 5 millimeters. The reason behind it is that long term. So let's say this holds and your patient, it holds. He gets to 21, and because it was a fracture as well, and they want to put in a post as well. If although I do think the root to crown ratio is not great, but for future reference, if your patient wants a crown, it's a post and core crown, it's advisable that you just fill in the MTA 4 to 5 millimeters and then use your womb GP for the rest of the canal. And then this was the third case. So this was a patient, 11 years old. He came in with painful teeth. That was his actually main complaint. And he came in 2 months after the trauma. I think he was playing soccer. So most of my patients, interestingly enough, are boys. He was playing soccer, and we did a pulp test, and the test lingered with cold. So we did consider partial pulpotomy with these teeth, but when we opened it up, under magnification, the pulp looked mostly necrotic. There wasn't a lot of bleeding, and then we decided to just do an ERCT. Okay, as you can see from the X-rays, we had a post-op and then a 2 months follow-up. So the patient is actually in ortho getting a retainer, a removable appliance for his front teeth to push them back as well and to give him an aesthetic look to his teeth. So this was actually a very nice case. Okay, so other treatments include your regenerative endodontic therapies. So this is treatment done on immature teeth with pulp necrosis, and they must have enough coronal tooth structure to cover it. Okay. So their aim is to stimulate the growth of tissue into the root canal and to deposit any hard tissue. Okay. So we're trying to stimulate growth into the root canal. Okay. So this is a fairly new treatment that's being done. So there's a lot of case studies out there that show that it is actually possible. So what happens is that your patient comes in, okay, you access the canal, you disinfect it with sodium hypochlorite, and then you place 3 mix. That's your antibiotic mix. It's a mix of 3 antibiotics, okay. And then you just place a temp on it. Then in the second appointment, you rinse the canal again. And then what you do is that you induce bleeding from the periapical tissue. The bleeding forms, and then you place a collagen membrane. So that collagen membrane that I always call it the collagen sponge actually acts as a scaffold. Okay. And then on top of it, you place MTA, and then you place the restoration. The key thing with this is that you must do follow-ups. As you can see, that a calcific barrier began to form. Okay, there was no longer an apical radiolucency in this case. And you can see that there was an increase in the root walls as well. Okay, so it's very important you follow up every single time. Okay, so in this case, this was a case study done overseas. So the patient, there was an avulsion basically. The patient came in, they re-implanted the tooth, and then they did regenerative endodontic therapy. Okay, and it seems to have lost it. The tooth is still in the mouth. So I always say, rather, for space maintenance, as I said, one of the important things is that we are trying to maintain the space. So even if this kid later on decides, you know what, I want whether to take out the tooth if it has an ankylosed, and I want to put in what you call this? Either whether it's
Implant.
Thank you, Dr. Osman, an implant, yes. Okay. Then the bottom x-rays was actually an intrusive luxation. Okay. So as you can see, there was actually ankylosis, but the tooth lost it. They kept the tooth for as long as possible. So they make good space maintenance. Instead of having us to take out the tooth and give the patient, a small kid, a denture, in cases like that, other people do crowns and bridges and help with the patient, but I think it's better to keep it as a space maintainer. And this is one of the therapies you can do to help your patient. Okay. So in conclusion, it's very important, I stress this to begin with, is that you need an accurate diagnosis. It's one of those things where even if you make a mistake, I always say lean on the conservative, okay, first. And then if you tell your patient, listen, especially the parents, listen, we're going to attempt this, okay? Especially if you open up, your pulp is bleeding, you can actually stop the bleeding as well. Then I say always go for minimal intervention. It's very important you look at the clinical. What are you seeing clinically? What are you seeing radiographically? Because a lot of the case studies in literature actually show that teeth that have irreversible pulpitis, that have tested as irreversible pulpitis, have actually been not. They haven't been, and the treatment has been successful. Because even if you have a case where it's successful for 2 years, the tooth has held on for 2 years. In those 2 years, the root has fully formed. You have cases like that. Now, even if your patient comes back symptomatic, you can do a normal root canal because your apex is closed. So, and the material that you use, it's very important that you create a protocol for yourself that you know, okay, this is the gold standard. I'm giving this tooth a fighting chance. Okay, your MTAs, okay, your biodentine, as much as they are expensive, this is the material that's been known as the gold standard. This is the material that actually really works. I only use MTA. And then regular follow-up. You do your 3-month, you do your 6-month, you do your 12-month, and you monitor that too. Because later on, as I said, the patient might need a root canal. They might need non-vital bleaching because later on we notice that they start to discolor. So there are those cases that you do. So my parting words are try it. You only get good at something once you try it. And even if you make mistakes, that's okay. I think the only way I got to do this was by trying. And I inform my patients, okay, you don't tell your patients this is your first time. It's a bit unethical and makes them nervous. But the more you do it, the better you get at doing something. So this is something you can try, managing your patients as well. It's a skill you learn. It really is a skill you learn, but I want to encourage that we need to stop extracting teeth, even if it's the easiest thing we can do. we need to stop extracting teeth. I think coming up with the treatment plan, explaining to patients and their parents that, listen, this is what we want to do. If this doesn't work, then we move on to this. Being transparent and informing them that it's important that we keep the permanent tooth as well. Because a lot of parents, because they haven't slept at night, they're not interested. They'll come in and the first thing they say to you is take it out. And yet it's a permanent tooth. I mean, what's the kid going to do without a central incisor? So let's actually start these treatments, and it's a fun journey. I always think of it as a fun. I enjoy doing these things. It's challenging, but a lot of fun. Okay, so last thing is we have an IAPD Congress coming up, which is exciting. It's the first ever on the African country. So this is me inviting you. It's going to be amazing. There's going to be an on-hands course, pre-Congress course as well on vital pulp therapies and immature teeth. So that's also exciting. You can sign up for it. You can learn it. It could be something you include it as part of treatment in your practice instead of referring it. As you can see, you can register online. Okay, you have access to all the Congress sessions. It is advisable that you join IAPD as a member because it makes it a lot cheaper. You get a discount on the tickets as well. And there's also a promo going on that you can pay 50% now when you register and then finish off the payment end of June. So I really hope you join us. I will be there. I am super, super excited for the IAPD. It is going to be amazing. And if you do have cases, if you want to submit an abstract, the abstract submissions are open. Submit, start presenting what you do in the practice. A lot of us can learn from each other. And that is it. Thank you very much.
Thank you, Dr. Kudenga. That was a very informative presentation. I would like to remind all the attendees, those that missed the opening, the CPD will be uploaded within 5 days to the Health Professions Council, and you should receive confirmation from them. Dr. Kudenga, I see we have some questions. I'm just going to read them out to you, and perhaps if you could answer them live. How do you manipulate MTA into a cylinder? Or how do you apply the MTA?
Oh, okay. So you get MAP systems. This is a fancy, it's a fancy device. I can't remember who makes it. But to be honest, I'll be brutal. I don't work for any dental company. That thing doesn't work for me personally. What I found works is your amalgam carrier. You take your amalgam carrier, you put it at the top, you squirt it in, and then you take your condenser, your vertical condenser, you measure your working length and you push it in. That actually works the best. Sometimes you can take a GP, the back of a GP, and also push it down using that. And it makes it a lot easier than that MAP system personally. I tried to use it twice. It did not work for me. So the amalgam carrier is literally God's gift to it. Really. It now has a purpose now that we no longer use amalgam.
It's reuse, recycle,
Yes,
recycle.
exactly.
Many of the practices have them and don't use them.
Yeah,
now it's
exactly.
another use for them.
Yeah.
All right. The next question. Do you use silver diamine fluoride? And if so, in what instance?
So
SDF.
SDF is basically, you use it for primary teeth. So it's a very preventative way, preventative option. So where your kid, as long as there's no irreversible pulpitis and you don't expose the pulp, that's one of the biggest thing. So if a patient comes in and they are very anxious, they're not interested in sitting down, SDF is an example, is one of, I think it should be widely used, especially in primary teeth. I know some of the SDFs, it comes out black, but in terms of helping your patients, it's the best thing that ever happened to primary teeth, especially for those patients, whether you're in a place where your patient can't afford conscious sedation, your patient cannot afford theater, use SDF. And we have a lot of courses. It's also going to be at IAPD. They're going to speak about at SDF as well. and when and how to use it. But it's the best thing for primary teeth. Really, really, especially when kids are uncooperative and they're screaming like the videos I showed you, and your ears you're losing it. SDF really, really works.
Thank you. The next question. What type of analgesia would you use for a permanent first molar? Is regional infiltration sufficient?
So there's the rule of 10. So depending on how old your patient is, we always use the rule of 10 in the hospital. So what we say is that if your kid, for example, is 7 and you're injecting the 6, that's 7 plus 6 is 13, then you're going to give a block. So you do get the stop pin where you can give a PDL, but normally the blocks work. Actually, a block for a molar, especially lower molars, is actually the best. Your patient doesn't feel a thing. And if you have the stop pin that injects very slowly and it's a painless injection, I say painless injection, then give a block. Definitely give a block, especially for the lower. Upper, you can infiltrate.
Thank you. The next question. Can you use a MTA root canal based root sealer?
MTA-based root sealer.
Yes.
Yeah. No, you just need to use not root canal sealer. I wouldn't. It's too wet. There's the Pro Root one, which comes in the package with which you use with the sterile water, and you mix it up. You do get your MTA, the flowable ones. You can use that. I think GC makes one. The ones where it comes in a syringe and you can inject them. You can also use that. They're a bit more pricier, but you can actually use that.
Thank you. When do you consider RET as opposed to apexification?
Oh, okay. So if, as I said, if it's not a big, if it's not a big like a fracture, I would consider it. If you're making a small incision, I would also consider it. So the key is that you must have a lot of your coronal structure left. It's very important that you have your coronal structure left. And even if, because remember with REP, if that doesn't work, you can always do an apacification anyway. It's the least invasive one. So you can always try one. Then if that doesn't work, you move to apacification.
Thank you. The next question is SDF on permanent teeth. You seem not to be keen on that. Could you just care to elaborate on that?
Okay, it depends. I think I think it depends on your own. I've never used SDF on permanent teeth. I think a lot of people probably have, especially posterior, but I mean, in terms of permanent teeth, if it's an adult and they're cooperative, I mean, restore it. Okay, because you remember you're also trying to get back function as well. Okay, so it's a material that was created as well. If you're in a tough situation, there's no drill, there's no water, you're in the rural areas, why not use it? Okay, so you can, I think it's just, I've never put SDF on permanent teeth because of the color as well. A lot of patients don't like to see black, and you also want to remove the caries as well before putting anything on. So I would recommend just restoring it. If you can restore it.
Hopefully the adult is more compliant.
Yes,
And
that's
then you
the
could do a
hope.
proper caries removal and restoration.
Exactly.
Okay. I think this question has been answered already. And there is a medical aid code for MTA. And there is this question is more about medical aids allowing for apexification and apexogenesis. Different schemes will have different rules regarding their benefit structure. One must always try and remember that you as a practitioner need to make your own clinical judgments and do the treatments that you see fit.
Yeah.
You can have a discussion with your patient and inform them what you feel needs to be done. You can then inform them what the medical aid covers. And if there is something that you feel strongly about, you should educate the patient and motivate them to fund it themselves. We cannot do our treatments based on the guidelines from what medical aids cover. That is what we need to remember as well.
Yeah.
All right. I don't see any other questions. I'm going to give 3 more minutes for anyone to answer any question. Oh, here's them coming in now. What material do you use for non-vital primary teeth, and how do you place it into the roots?
For non-vital primary teeth. And how do I non-vital primary teeth? So your pulpectomies, I'm assuming. You can use vital. So a with the non-vital primary tooth, it's a normal root canal. You use your Vitapex. You can use a S6 rotary file, and then you squirt in that Vitapex. Because remember, you're just trying to keep the tooth as long as possible, and it's gonna fall out. As long as there's no resorption.
Space maintenance.
Yeah, space maintaining. You're trying to maintain the space. So you do your normal pulpectomy.
Okay, I think that about answers everyone. I would like to take this opportunity to thank Dr. Kudenga for presenting to all of us. Secondly, I would like to thank the people attending. It's quite a huge turnout, and we are really appreciative of that. Thank you so much for sharing this with us, and we look forward to seeing you at our next webinar. Also, I'd like to thank the team at head office, Marlies, Ruth, all of the people that make this magic happen and bring you education and CPD points in the comfort of your own home. Also, I'd like to just remind everyone that we do have the SAAPD Congress as well that will be happening in 25th, 26th, 27th July. And this time it will be in the lovely city of Durban. So I encourage everyone to register and join us in Durban. And just some commendation to Dr. Kudenga for a very wonderful presentation. And I think that brings us to the end of tonight's webinar. I trust each and everyone keep well and hopefully start seeing more pediatric patients, and let's build a better oral health for everyone for the future. Thank you very much.
Thank you,
Good
Dr.
evening.
Thank you. Good night.